everyone, and welcome to the special Black History Month conference hosted by MS Focus, the Multiple Sclerosis Foundation, made possible with support from Biogen and Genentech. I am your host, Kimani Hendricks, and I'm the Multimedia Communications Coordinator for MS Focus. And tonight our speaker is Dr. Kalina Sanders, who will be talking about MS in the Black community. And after the presentation, we will open it up to your questions and comments. Kalina Sanders, MD, is a board-certified neurologist with Baptist Neurology in Jacksonville Beach, Florida. She completed her internal medicine internship and neurology residency at the University of Florida, Jacksonville. In her previous faculty position at UF Health Jacksonville Comprehensive MS Center, she participated in clinical trial research and resident education. She is currently with Baptist Neurology in Jacksonville Beach, Florida, where she is a partner in MS Care. She continues to participate in clinical trial research, including those targeting minority populations. She is a former member of the National Medical Advisory Committee and is a current chair of the Florida Healthcare Provider Council with the National MS Society. And she has been treating patients with multiple sclerosis for over 10 years. And we're pleased to have her join us to present this important topic. Dr. Sanders, thank you so much for being with us tonight, and I'll turn it over to you.
Awesome. Thank you, Kimani, for that kind introduction. I am always excited about educating people living with multiple sclerosis. I am even more excited to share the up-to-date research that is available regarding MS in the Black community. Before we get started on MS in the Black community, I think it's important for us to understand our ancestral backgrounds and understand how MS affects Black Africans. To put things into perspective, the first well-described case of demyelinating disease in Black Africans was not until 1987. Well after we have known this information in other countries and continents. And it was felt that multiple sclerosis was rare among Indigenous Black people. The Atlas of MS, which is a collaboration between the Multiple Sclerosis International Federation and the World Health Organization, is a comprehensive worldwide study of the epidemiology of multiple sclerosis. So this is our most accurate and up-to-date estimate of the number of people living with multiple sclerosis worldwide. And in the most recent edition, published in 2020, we have the best numbers that we have to look at the number of patients in the continent of Africa who suffer from multiple sclerosis. And as you can see on the left side of the screen, it talks about prevalence. This is the number of people in total who are living with multiple sclerosis. And when we compare the numbers in, let's say, the European countries or regions, we can see that there is 133 per 100,000 people in that region living with multiple sclerosis. When we compare that number to the continent of Africa, that goes down to 5 per 100,000 people. So there is a significantly lower number of people in the continent of Africa that are living with multiple sclerosis. This is compared to the United States, where the prevalence of multiple sclerosis is about 288 per 100,000 people. I'll off my mouse, hold on. And when we look more specifically at one of the countries in Africa where we have some information, we still see a difference between the white Africans of that country versus the Black Africans in that country. So in the country of KwaZulu-Natal, the prevalence of multiple sclerosis in the white Africans in that region is 25 or 26 per 100,000 people. And that's compared to 0.22 in the Black Africans in that region. And it was because of this that we always assumed or felt that multiple sclerosis was also rare in the African American population. But we know that these numbers are different for African Americans. The prevalence of multiple sclerosis is higher compared to the Black Africans. Now, this could be due to the genetic admixture of the African American population. It is estimated that an African American has anywhere from 10 to 20% European ancestry. And so it may be the impact of that part of our genetic background and maybe environmental factors that are specific to the United States that contribute to the increase risk for developing multiple sclerosis, and that we are now seeing much higher numbers than we would have expected. So what does MS look like in the Black community? I will begin by saying our knowledge about how multiple sclerosis impacts the Black community is very limited, although the number of research articles are definitely increasing. There was a PubMed review paper that was done in 2014 that revealed out of 60,000 published articles in multiple sclerosis, only 113 of them actually focused on African Americans. There was a subsequent paper about 5 years later that actually found that less than 30 additional articles were published where the article was focused on African Americans. So if you add those numbers, we're only about 140, 150 articles out of 60,000+. So we definitely have some room to grow in our knowledge of multiple sclerosis in the Black community. A lot of our understanding of how MS affects the Black community comes from observational studies, or studies we call retrospective studies. These are studies that take a group of people and with a diagnosis, and they look back over their history and try to draw out of the chart or conversations with the people to understand what characteristics about their disease. But this has a lot of limitations. They are usually small patient numbers. They oftentimes are isolated to one clinic or a small group of clinics. So the chances of having a diverse patient group, even among the African American population, is limited. Additional limitations that can exist in observational studies is that they oftentimes do not account for socioeconomic factors such as health literacy, access to healthcare, insurance coverage, and social beliefs. So as we go through the slides, I want to put that into the context so that we understand how limited the data we have. But let's take a look at what we do know. A study done in 2013 looked at 500 newly diagnosed patients in the Kaiser Permanente health system. And in this study, they found that there was a 47% increased risk of MS in Black people compared to white people. The highest incidence rate was actually found among the Black female. There was a 59% increased risk of being diagnosed with multiple sclerosis in the Black female compared to the Caucasian female. And we also found in this study that the African American female was 3 times more likely to be diagnosed with multiple sclerosis as the African American male. And when they looked specifically at the risk for developing multiple sclerosis between the Black male and the Caucasian male, they found that they were actually of similar rates. So the person or the group that really is the big contributor for this increased risk is actually the African American female. So let's talk about what some of the risk factors may be. We know that in patients who develop multiple sclerosis, we feel that there is a combination of factors, whether or not that is environmental factors such as vitamin D deficiency, exposure to previous viruses. The most commonly linked one is the Epstein-Barr virus, and someone who is genetically susceptible. So what do the genetic studies tell us about the risk factors for the susceptibility of developing multiple sclerosis in the Black community? There is one gene that is highly associated with the risk of developing multiple sclerosis, and it is this HLA-DRB1 gene. And this is the gene that helps to tell our white blood cells how to recognize what's foreign and what is known to them. And this is one of the genetic abnormalities that in the general population of multiple sclerosis increases the risk of developing MS 2 to 3 times. And so what one study has shown is that in those African Americans who has this genetic abnormality, and it is associated with more of the European or that Caucasian ancestry part, they are at 3 times higher risk of developing multiple sclerosis. However, there was no difference in association with risk of MS with any novel or unknown genetic variants among African Americans. So to date, there has not been identified a specific gene in African Americans that increase their risk for multiple sclerosis. Again, there was another study published in 2013 that looked specifically at 1,000 African American people living with multiple sclerosis. And among 73 non-HLA genes, so a different set of genes that are associated with MS among white Americans, only 8 of them were actually associated with MS among the African American population. And so we found again that that HLA gene was also seen to be lower in prevalence in the African American population. So we still have a lot of information to glean from genetic testing done in this population, but as to date, we have not identified a specific gene that is for African Americans and their risk of developing multiple sclerosis. Let's talk about another risk factor, vitamin D. So we know that vitamin D is an important player in our immune function, and the presence of vitamin D in our lymphocytes or our white blood cells really dictate how inflammatory they are, or whether or not they produce chemicals that decrease the amount of inflammation. In a study that looked at vitamin D levels in multiple ethnic groups, they found that higher serum levels of vitamin D in the African American population was not associated with a lower risk of MS. However, they found that the lifetime sun exposure appeared to reduce the risk of MS regardless of the race and ethnicity. So these patients were getting the same amount of vitamin D from the sun as the Caucasian population. However, because even though they had higher levels of vitamin D, it did not seem to lower their risk. So there is some theories around this. There's a theory that the African Americans express different dominant isoforms of the vitamin D transporter protein. And what that means is that it's felt that maybe the vitamin D is not getting to the appropriate white blood cells that it needs to decrease the amount of inflammation. Again, these are still very early on theories. There is nothing that has been shown to significantly contribute to this, but these are some observations that we are seeing. We do also know that in general, compared to Caucasian counterparts in another study, that African Americans tend to have lower levels of vitamin D compared to controls. And this might explain the difference in the climate and the geography. We know that in patients who are people that live further away from the equator, their risk of developing multiple sclerosis is low, and that may be part of that environmental factor. But there has been no association, and at least in this study, between vitamin D status and disease severity. So that's what we know about the risk. What about the presenting symptoms of multiple sclerosis? Is there a difference in the African American population compared to the Caucasian? And so what we know from, again, these very small observational retrospective studies is that there is an increase in occurrence of multifocal signs and symptoms. So when a person presents with multiple sclerosis, they may have more than one thing going on. There oftentimes seems to be a more optical spinal presentation. So that's involvement of the optic nerve. So vision is a big presenting symptom, or loss of vision, I should say, and spinal cord disease. So our patients that are African American tend to have more weakness, more sensory loss, severe ataxia. The brainstem is also commonly involved in the way that African Americans present. So we oftentimes will see more tremor and incoordination. And then cognitive function has also been shown to be more prevalent at the presentation of multiple sclerosis. What do we know about the diagnosis? So there are several different studies that have looked at the time from when symptom onset to actually getting the diagnosis in different ethnic groups. And it does appear that the diagnosis in African Americans occur 1 to 4 years earlier after the onset of their symptoms compared to their Caucasian counterparts. And this is felt maybe due to the severity of the symptoms that a patient presents whom is African American compared to the Caucasian. So it's quite clear the diagnosis that they have, so that we are now able to diagnose them earlier. A retrospective chart review looking at the age of diagnosis in one study showed that there was no difference. In another study, they found that the age at diagnosis for the African American population was about 2.5 years older than their Caucasian counterpart. And this was also a theory of why the symptoms from a patient who is African American is more severe at the presentation. But despite in this retrospective study, the ages being similar, the average disability status was worse at the diagnosis. So let's look at MRI activity. So our clinical symptoms is one feature of the inflammatory activity, but the MRI is a very strong biomarker looking at the diagnosis of the disease, as well as the surveillance and monitoring of the disease activity. And so what do we know? Looking at special MRI techniques, it is known that African Americans have 31% greater amount of T2 lesion volume, which is this picture here. And they're also found to have 101% greater amount of T1 lesion volume. The T2 lesion volume that's here in the middle panel is really a representation of overall disease burden. But the T1 black holes is an indication of the neurodegenerative process, or the axonal loss that can occur in multiple sclerosis. Studies have also shown that gray matter and the white matter of the brain, as well as some central structures such as the thalamus, also has atrophy rates that are double the Caucasian time period. And so what we are seeing is that the brain shrinks or atrophies at a much faster rate compared to the Caucasian counterparts. And when we look specifically at disease subtypes, we do see, and again, and I'll point out this on this slide, that we're talking about very small numbers. We're talking 79 African Americans compared to 80 Caucasian Americans. And so when we look at these small numbers, we do see a higher proportion of patients who have primary progressive disease, 22% in the African American group versus only 9% in the Caucasian counterparts. And then we also see a higher prevalence of secondary progressive MS compared to the Caucasian counterparts. Another interesting biomarker looking at the nervous system is the layer in the back of the eye called the retinal nerve fiber layer. This is evidence of the end organ extent of the central nervous system. So through the use of a technology called OCT, we're able to look at the retinal fiber layer in the back of the eye. And that might be an indication or areas where we can see the neurodegenerative process of multiple sclerosis. And so when we're looking at the the retinal fiber layer at the back of the eye at baseline, there was no difference in the retinal nerve fiber layer compared to the African American population compared to the Caucasian population. Also, at the beginning of this study, there was no difference in the prevalence of a diagnosis of optic neuritis. However, when these patients are followed along, there is actually a much faster reduction in the level of that nerve fiber layer compared to their Caucasian counterparts. And it was felt that an optic neuritis history may predispose these patients to a greater degree of visual impairment compared to their Caucasian counterparts. So we're seeing evidence by OCT looking at worsening or faster progression in the neurodegenerative aspect of multiple sclerosis. What is the disease course? How do patients tend to progress or change over time? What does their journey look like? In one study, they found that African American patients had more aggressive disease course. As I mentioned early on, some of the presenting symptoms tend to involve the spinal cord. And when we think about the nervous system and someone who has a lot of lesions in the brain is a very large structure. There's a lot of redundancy in the brain. There's a lot of reserve that the brain can handle. But all of the information in the brain gets funneled down into the spinal cord. And so when someone has a lot of spinal cord disease, it does not take much to knock out a lot of function. So it was felt that the disease course in our patients who were African American was primarily due to the impact of their spinal cord disease. Again, the age of onset in one study was about 2.5 years later. So we know that age is a contributor to disease progression over time. They also found a higher prevalence of the cerebellar disease or dysfunction, so more ataxia and imbalance, more tremor. And so because of this, our patients tend to have more mobility issues. So our patients who are African American tend to have a higher need or dependency on the cane, and they tend to need it in a sooner amount of time. So it's felt that the African American would require the use of a cane 6 years sooner than their Caucasian counterparts. And also because of the advanced disability, our patients African American patients are requiring admissions to nursing homes a lot sooner than their Caucasian counterparts. Let's switch gears and talk about disease-modifying therapy trials and wondering whether or not there is a difference. I will say one main limitation is the underrepresentation of African Americans in clinical trials for disease-modifying therapies. All clinical trials for multiple sclerosis medications have at least less than 10% African American, with most trials enrolling less than 5%. So while African Americans represent 12 to 13% of the US population, we are making up only 5% of clinical trial participation. Therefore, it is difficult to know the true effects of disease-modifying treatments in the Black MS community. But let's see what we know. One of the early studies looked at the effectiveness of interferons. If many of you have had MS for a number of years, you may have been on beta-seron or Rebif. And there was one study that looked at the effectiveness of Avonex, which is one interferon, versus another. And in this clinical trial, there were only 36 African American subjects, and that's compared to 616 Caucasian subjects. And so the data that we have is very limited and should be taken with a grain of salt. But in that clinical trial, as you can see in the bar graphs on the slide, that there were slightly more relapses in the African American subjects. So here, depending on which dose of the interferon that they received, we see that the bar is higher in the African American compared to the Caucasian Americans in both of those treatment arms. They also saw more MRI activity, so more new T2 lesions compared to the Caucasian counterparts. Now, this data was not statistically significant, but it did show a trend in this small cohort of patients. And so it was this data that's really sparked a debate on whether or not interferon therapies was less effective in African American patients. I will highlight again that the numbers were so small that we should definitely take that with a grain of salt. What about other medications? So natalizumab or Tysabri, in their pivotal clinical trials, there were 49 patients who were African descent compared to, there were 49 total patients that were African American, and that's out of 1,200 MS patients in the clinical trial. What they found was that there was a statistically significantly reduction in annualized MS relapse rates of about 60%. And that's compared to 68% that was seen in the general population. So there was a suggestion may have been a slight reduction in the effectiveness of natalizumab in the African American population compared to the general group. The mean number of GAD-enhancing lesions was reduced by 79%. The mean number of new or enlarging MRI lesions was decreased by 90%. So the medication was found to be effective in our patients who were African Americans. But again, this was drawn off of a small number of patients. When we look at fingolimod or Gilenya, in that clinical trial, there were 3 different arms of the clinical trial, and you can see here the breakdown of the FDA-approved dose of 0.5 milligrams. There were only 24 patients in the clinical trial that were African Americans. 25 were in the higher dose, and 28 were in the placebo group. And what they found is that the annualized relapse rate had a reduction of about 29% in the 0.5 milligram dose. And that's compared to the overall study population reduction of about 52%. So maybe a possible slight reduction in the effectiveness of the medication. There was a 54% reduction in the much higher dose that was not FDA approved. Again, drawing information off of small numbers of patients, so we have to be cautious with our interpretation of the results. And then dimethyl fumarate. So you can see here, compared to 261 Caucasian American enrolled in the clinical trial, 69 were African American, even fewer were Hispanic. In this set analysis, they found that there was no difference in the annualized relapse rate and no difference in MRI activity. And then lastly, ocrelizumab. So Ocrevus enrolled in their clinical trials 72 patients of African descent. That only represented 4.3% of the overall study population. And they found in this subset analysis that the efficacy outcomes were consistent with the overall population. However, they did note that there was a higher baseline lesion burden, and those patients who were in the interferon group developed more lesions. They were also at greater risk of developing progression through the clinical trial, and they also tended to have more adverse events and hypersensitivity reactions. And so lastly, there is the North American Research Committee of Multiple Sclerosis Registry, or NARCOMS, which is a global patient registry that is used to understand the patient experience to help improve clinical care and quality of life for persons with multiple sclerosis. If any of you are a part of NARCOMS, you are probably familiar with receiving a lot of questionnaires and registry studies. And so we are able to glean the patient experience through this registry. And what has been published from the NARCOMS registry is that African American experience greater multiple sclerosis associated disability than Caucasians. So somewhat in line with what we are seeing in some of our observational clinical trials. They have also reported disease progression that is similar though between the two cohorts. So why is there a difference? Is it a reduced capacity to remyelinate? So maybe there is an innate inability of the nervous system to remyelinate or repair itself. Is there a difference in exposure to environmental factors? So we mentioned specifically vitamin D, but is there a difference in exposure to prior viral? Is there an increased risk for smoking, which is also known to increase the susceptibility of developing multiple sclerosis? Are there truly genetic differences? And then I would also like to highlight, is there any socioeconomic status or healthcare access disparities to explain this difference? The answer to this question is we don't know. I think it's important though that we start to research and gather this information. But let's talk specifically about healthcare disparities and the role it plays in some of the numbers that we may be seeing. I think it's important to highlight health literacy. Health literacy is a topic that is just now coming into the limelight in looking at how it impacts outcomes in our patients with chronic disease. Health literacy is more than reading ability. but really is an understanding of how to maneuver around the complex healthcare system. How do we get doctor's appointments, understand instructions of our medications, understand the literature that is provided for us to read, and how does that come into play with the adherence to our treatment regimen? It is felt that in the African American population, and particularly in those in whom there is a lower socioeconomic status, that there is lower health literacy in that population. So it is upon the healthcare community to make sure that patients in that population truly understand their disease, understand the role of the medication, and how to access it. That leads me to my second point, which is access to healthcare. We also know that those patients who are underinsured or uninsured don't have the access to seek the care that is needed in order to get on the appropriate disease-modifying therapy or symptomatic treatment for multiple sclerosis. So oftentimes those patients who have who are uninsured are oftentimes seeking care in the emergency room. And the providers in the emergency room are ill-equipped to help with the ongoing progression and issues that are needed to fully take care of patients with multiple sclerosis. I would also like to add the social beliefs and biases. And so this is actually a two-way street. So there is the social beliefs and the possible distrust in the healthcare community from the patient side. And then there's also some inherent biases that exist in the healthcare provider and understanding really what our patients need. All of this is involved in the numbers that we are seeing. As it relates to access to care, one retrospective study looked at the difference between treatment and the time of treatment of getting our disease-modifying therapies. And they found that between the African American population and the Caucasian population, there was really no difference in the treatment or the time to treatment. However, the African American population were less likely to switch therapies. So even though the current treatment that they were on was not effective, either they were not having or feeling comfortable with having that discussion with their healthcare provider, or maybe their healthcare provider felt that the patient was unwilling to switch to a more effective agent. And so African Americans tend to have less switch of their therapies. They were also less likely to use IV solumedrol for acute therapies or acute treatment, of their MS. There was another study that looked at members who were diagnosed with multiple sclerosis in this independence care system, and they surveyed three aspects of their care. They surveyed whether or not they received specialty care, whether or not they were using immunomodulating drug therapy, and whether or not they were having the access for osteoporosis prevention. And what they found in this study, that 32% of those African-American patients that were surveyed were never seen by an MS specialist. That can oftentimes have a huge impact on their control of their disease, making sure that they are receiving the right disease-modifying therapy as well as symptomatic therapy could be the difference between seeing a general neurologist versus an MS specialist. 1/3 of them were not taking an immune modulating medication. And this was primarily due to non-compliance, due to lack of understanding of what these drugs meant. And that goes back to the health literacy that I discussed before. And it is on the healthcare community to make sure that we are having the appropriate shared decision-making visits with our patients, that we're discussing the importance of adherence to the disease-modifying therapies. And they were less likely to have their osteoporosis prevention studies looked at. And this was felt to be largely neglected by their healthcare providers. So what can you do? You can stay informed, you can be proactive, ask questions to your healthcare provider, making sure you understand what the role of your disease modifying therapy, what your expectation for your disease modifying therapy, and making sure that your symptoms are adequately controlled. You can adhere to your treatment plan as well as participate in clinical trials. So ask your healthcare provider what clinical trials may be available to you. I think it's important to know that there are many types of trials that provide valuable information. There are those clinical therapeutic trials, but there are also other non-drug treatment trials. There may be surveys in NARCOMs and the in NAAMSR, and we'll talk about that in a moment. And then there may be journaling or logs or interview and focus groups so that we can get a true representation of the impact of multiple sclerosis in the Black community. So specifically, and most recently, there's the National African American with MS Registry, in which the mission of the registry is to accurately estimate the number and the geographic distribution of African American people diagnosed with MS in the United States. They hope to gather information about barriers to access to care and strategies in which that we can undo these inequities to the access. So if you have a moment, there is their website, www.naamsr.org. Go on, sign up, and provide as much information about your MS as you can. All right, so in conclusion, MS affects the Black community in different ways compared to other ethnic groups. The Black MS community is definitely underrepresented in research studies, and it is critical for us to understand and address barriers in the Black community and to promote participation in MS research. So with that, that will conclude my part of the presentation. I will open up the chat box or raising your hand for questions. So thank you for your attention today.
Wow. Thank you so much, Dr. Sanders. God, so informative. So we do actually have some questions, but before we jump into them, if anyone's watching on Zoom and you don't know how to ask a question, and if you would like to, you can make use of one of the three features at the bottom of your screen. You can either type your question into the Q&A or the chat box, or you can raise your hand so that you can speak directly to Dr. Sanders. And of course, if you're watching from Facebook Live, you can just type your question into the comment section and we'll get to you as soon as possible. And the first question actually comes from Facebook. It's from Joel. He wants to know if the prevalence is lower due to lack of testing or being misdiagnosed.
I'm assuming you're asking about maybe in the continent of Africa, seeing those lower numbers. As in one of the slides, I did not highlight it during the presentation, but it showed the map. And there are several countries in the continent of Africa that they are not able to get the adequate numbers or records from. And so when we're talking about the prevalence of MS, it tends to be in the more populated parts of the continent and countries where they can actually gather that information. And so that is quite a possibility that there may be other areas within the continent of Africa where MS does exist and we're just not gathering that information. But I do think despite that caveat that there is definitely still a lower number or lower risk of developing multiple sclerosis, and the indigenous people of the continent of Africa in general, and specifically the Black Africans.
And Joel's second question is, have you looked at people that have mono or kissing disease?
So there has not been any studies that specifically look at African American population and someone who has had mononucleosis or exposure to the Epstein-Barr virus. But there was a recent study that really highlighted and reinforced the role of the Epstein-Barr virus as the trigger for the autoimmune response that we see that leads to multiple sclerosis. I don't know if any of you are familiar with that recent study that was based from a military cohort. And they looked at, there was a strong association between Epstein-Barr virus exposure and seroconversion to the onset of multiple sclerosis. And so that is seen in the general population, but I don't think that there has been any specific results in just the Black community.
And we have a question from Tracy in the chat. She says, are you doing more studies, or are they doing more studies on Tysabri in African American patients?
So I don't think that there's any specific studies that are ongoing looking at the African American population and the use of natalizumab or Tysabri, but I do see also in the chat, or any other agents. I will say that there was a recent study that enrolled patients who were African American and Hispanic with the use of Ocrevus. It's called the CHIME study. It was spearheaded by Dr. Mitzi Williams and was hoping to glean that information about the impact specifically in the African American and Hispanic population. And the clinical trial has enrolled over 100 people. And so we will understand prospectively how Ocrevus impacts those subpopulations. I'm not aware of any ongoing or upcoming trials with any other agents.
Okay. We do have several in the chat and in the Q&A, so I'm going to jump around, but we are going to get to everybody's questions. Travis, I see your hand is raised. If you wouldn't mind unmuting yourself, and you can speak directly to Dr. Sanders whenever you're ready.
Hello.
Hi, Travis.
Hi, I would like to know, we're not in Africa, we're in America. A whole lot of us we're Black, but we're not fully Black. We're, as they used to say, mulattoes. Mm-hmm. Does that affect the way that we have multiple sclerosis? Because I've been on Avonex for my whole time I've been diagnosed, and I got diagnosed late. And there's been no change. I've been on not Ocrevus, but Avonex for going on 9 years, and I've had no new lesions. Is it because I'm a mixed breed, as they used to say in the old times? I'm half Black, I'm half Native American, or indigenous people. Is that part of the reason?
Yes, so I mentioned early in the presentation that we definitely see higher numbers of multiple sclerosis in the African American population, and that is partly due to our genetic admixture. So on average, an African American has at least 10 to 20% European ancestry, and it is that's partly influencing the increased risk for developing multiple sclerosis, and may have an impact on how we respond to disease-modifying therapies. But I will say, with the caveat of the numbers that we talked about in the presentation, it is really based on a small number of patients, right? We know that there are close to 1 million people in the United States with multiple sclerosis. And when we're talking about 20 people, 60 people, it's really hard to extrapolate or generalize that to the general population of MS and African Americans. But you are right. I think it does possibly have to do with our genetic admixtures and the impact of our European ancestry and our risk.
Thank you.
You're welcome.
I think it's interesting because if our genetic makeup, including European blood, it can influence our chances and increase our chances of getting multiple sclerosis as Black people, and yet we have it more severely. I don't understand.
I don't think we know that, and maybe it is because of the mixture, right? So we're not purely Caucasian, we're not purely African, and maybe it's how those genes interplay and interact with each other that may be doing it. But we won't know unless we have the data, right? So if we are, participating, giving blood samples for the genetic repositories, that participating in family studies, that's the way we're going to get that information.
Yeah, it's a conundrum. I hope we do get it. So in the Q&A, question from Margot, she says, would African Canadians have similar numbers as Americans? Good question.
That's quite possible. When we kind of, again, look at the genetic ancestry and the background, obviously there are probably shared origins of some of the genetic makeup. So that is quite possible.
And in the chat, another question from Tracy. She says, do you have any stats specific to African-American patients who are on Copaxone?
There hasn't been any published data or subpopulation analysis looking specifically at African Americans in the Copaxone studies, and that may be partly due to the significantly lower numbers of patients who are enrolled in those clinical trials, that they didn't have enough to publish. But I'm not aware of any that has data that has been published about it.
And we have a thank you from Tanisha. She says this information is awesome and she just thanks you. Another question from Facebook, Joel. He says, why do you think African-American patients are not represented in research studies?
So I think it's, again, that two-way street, right? So there is the trust issues and the concerns from a patient standpoint. Obviously, we have our historical background of how African Americans have been treated in clinical trial research, specifically just the Tuskegee syphilis studies, the use of the cells from Henrietta Lacks. And so there is probably our historical distrust in the research, and making sure that our privacy is protected, that ethically it's done appropriately. There may be other socioeconomic impacts of participating in clinical trial research. So the ability to take time off of work to actually go to the research visits, which are oftentimes more numerous than what we would do in the general clinical practice of MS. There may be the inability to have transportation to get there. So there are some socioeconomic barriers. But I also think that there are some biases from the healthcare provider. And so one of the things that people will say is that no one ever asked me. So the healthcare provider may be reluctant to even introduce the possibility of participating in clinical trial research to a patient who is African American because of their own biases and their own fear that maybe that patient would say no, or that patient may be turned off from their care if they're asked to participate in clinical trial research. So I think those are the main reasons why African Americans are underrepresented in clinical trials. But what we have learned over time, and what myself as a healthcare provider need to share to other healthcare providers, is that African American patients are willing to participate, are excited about adding to the knowledge base that we have for multiple sclerosis. And so I am a study site for the CHIME study, which is looking again at Ocrevus in the African American Hispanic population. And everyone that I introduced the study to was willing to participate. And so we need to share that willingness with the general population so that at least African American patients are asked to participate, and then having that understanding and that willingness for the patient to agree.
Agreed. Pam, I do see your hand up, and just bear with us for one moment. Courtney asks a general question in Q&A. She asks how important diet is in the progression of MS.
So in general, the diet is extremely important. I don't have any information specifically about the Black community, but we do know that the anti-inflammatory Mediterranean type diet is extremely helpful for our body to produce the way it's supposed to. I tell everyone that our body has only a certain amount of energy, right? It can spend its energy healing itself. It can spend its energy repairing itself, keeping the immune system in check, or it can spend its energy breaking down complex sugars, breaking down saturated fats and oils just to get to the basic nutrients. So when we take away that job, that duty of the body to break down the foods and give it just its basic fruits, vegetables, lean protein, it can spend its energy doing what it's supposed to do, which is keep a homeostasis, keep inflammation down, and that in result has an impact on progression of the disease.
Pam, I am going to ask that you unmute yourself and you can speak directly to Dr. Sanders when you're ready.
Go ahead. Yes, yes, doctor. I'm a person that has had MS for over 20 years and is pretty progressed. And currently, my neurologist does not have me on any kind of medication because he says there isn't anything out there for my secondary progressive MS. I'm just wondering if people are looking at that secondary progressive MS, and how far down can I go? I mean, how far will this MS progress? I mean, is there a limit to it, or do you know, or?
Yes. So thank you for that question, Pam, and thank you for sharing your journey as well. There are a lot of scientists, a lot of pharmaceutical companies that are looking at agents to impact that neurodegenerative process to try to slow down the progressive nature of the disease. There isn't anything on the immediate horizon, but a lot of research that's going on. How far a person can progress with multiple sclerosis. And although I cannot predict your individual journey and how far down you can go, there is definitely a variability within the disease process and a heterogeneity, but there are patients that can almost become quadriplegic or bedbound because of their multiple sclerosis. Now, are we able to predict who will go that severe? It's very hard. It's very hard. And so it's difficult, though, as you kind of alluded to in your story about, what role our current disease modifying therapy has for that late stage of the disease. And unfortunately, they have not proven, or there have been no studies that really look at the impact at that point in the disease when you're no longer having relapses and have significant disability. So as I hope that your healthcare provider is doing is really supporting you, making sure you have the available resources to keep you functional and the best quality of life.
Thank you, Doctor.
Well, thank you for joining.
Thank you, Pam. Marla just wants to say thank you for providing this knowledge to the community. And we have a question from Joya. She wants to know if there's any information on how COVID-19 and its vaccines affect African Americans with MS.
There hasn't been any data that's published that's specifically to the African American population, no.
And our next question is from Tracy. She says, have we looked at how African Americans are treated versus their white counterparts? Are white Americans more likely to be on a DMARD? I don't know what that is. I hope you do.
I'm assuming disease modifying therapy is another acronym for that. And so there have been some small, again, retrospective or survey studies that look at the impact. And I did mention there was one study that looked at 92 patients and they surveyed and whether or not they had access to medication. And they did find in that small number of patients that they were all similar in their diagnosis and their actual being on a disease modifying therapies, but where they saw a difference is whether or not they would switch to a different disease modifying therapy should they have breakthrough disease or disability progression. So there may be a disproportionate amount of the effective use of disease modifying therapies, but patients are receiving disease modifying therapies. One argument for that may be, again, the lack of access to an MS specialist. And so that may be due to, again, those socioeconomic barriers. Maybe there isn't an MS specialist anywhere close to where you live. That might be a part in that access to care. Or the general neurologist in whom you're under the care with may not know when it's time to transfer their care or bring in the opinion of an MS specialist. So there are many things that impact the initiation and the continuation or the switching of a disease modifying therapy.
We have another question from Marla in the Q&A. She wants to know if you are bedbound, is there any coming back?
So unfortunately, when the disease has progressed to the point where you have low or poor mobility and are unable to support your core structure enough to get out of the bed, that oftentimes, if it's due to the progression of the disease, there's not a lot of room for a return of function. However, if you have relapsing remitting disease and it's an acute relapse, and that is what has forced you to become bedbound, there may be a role or opportunity for improvement after a relapse. But if we're talking specifically about disability progression and that slow change or decline over time, oftentimes there's very little improvement that happens at that stage.
And Joel from Facebook says he has one more question. First, he says it's unfortunate to hear that African Americans only make up 5%, of research, and he wants to know what he can do to assist with decreasing the lack of African American representation in clinical trials and or better education on the disease.
Talk to everyone. Tell everyone, ask your doctor, are there any clinical trials that are available for you in the area? Clinicaltrials.gov is a great search engine to look for all clinical trials across the globe. You can narrow it down to MS, you can narrow it down to your state and city and look to see if there are any clinical trials in your area, but really share the word, right? Tell everyone that in your support group, in your Facebook group, if they are not participating in any clinical trials, they should ask about it. I mentioned the North American African Registry, www.naamsr and .org, and join that registry. That's where we are going to gather that information about the African American population, but share the word.
So Joya wants to know if you are not able or limited in asking your African American patients to participate in these studies or make recommendations as an African American neurologist.
I am able. So it's not a fact that we are not allowed to or inhibited from doing it. It's just the comfort level of the healthcare provider. If I am participating in a clinical trial research as an investigator, I'm asking all my patients. And so it's really, again, about us as other researchers and healthcare providers to make sure that our counterparts feel equally comfortable breaching that subject with the African American population. And so again, African American neurologists, and specifically those who practice multiple sclerosis, is quite limited. There aren't very many of us. And so you may not have access specifically to an African American neurologist, but you should attempt to have that open discussion with whomever your healthcare provider is about, are there any clinical studies or registries I can participate in?
Courtney says, thank you for this. This is great information. And I saw a question. Oh, here it goes. Question from Latoya from Facebook. She asks, is there significant data in the research of how African-American women with MS compared to African-American males with MS? So guessing just, is there any information that maybe differentiates the experience?
The only difference that we have seen is the risk of developing multiple sclerosis. So the African American female is 3 times more likely to be diagnosed with MS than the African American male. But there hasn't been any further studies to delineate the disease progression or the disease presentation or MRI features between male and female within the African American population.
And Travis has another question. His hand is up. So Travis, go ahead.
The information I read said that the African-American male is more likely to be more severely progressed in his disease because he has MS. And I was diagnosed when I was 38. And as soon as I was diagnosed, I was walking with the cane. They gave me a wheelchair, and I actually had to use it. Gave me a power chair, a scooter. Thank God I was connected through the VA, or I wouldn't have had a chance to get those. And they gave me so many things, and it feel like my progression of my disease came down quicker. Yeah. And I sleep in a hospital bed. I can't sleep with my wife no more. So I was just asking, why does it differ so much from female to males? Like females, I see they have diagnosed mostly, they have pain in their eyes, and some of them can't walk like me. Mm-hmm. But it seems like it happens quicker to males. Can you tell me why that is?
Travis, I don't think we know why that is. I think there's definitely a heterogeneity of the disease. There are people that are going to be on the milder end of the spectrum, and there's going to be people that are on the more aggressive end of the spectrum in all ethnic groups. I do think that there is this assumption that MS is more aggressive in the African American male. And I think part of that is teased from bits and pieces of different information. So we have the assumption and the data that suggests that MS is more aggressive, more disabling in the African American community as a whole. We also have bits of information about the males compared to females in the general MS population, white or African American. And we know that in the studies that we have seen is that males tend to have, are more likely to have primary progressive MS. They are oftentimes more likely to be older at the time of diagnosis and have a slightly worsened disease course compared to their female counterparts. And that's, again, Caucasian, African American, the whole group as a whole. So I think where we have gotten to the conclusion that the African American male is the most worst off is because we are combining what we see in the African American population and what we see in males in general. We're putting it together. But even in my patient population, my African American males, I still see the spectrum of the disease as well. I see some patients with really mild disease 10 years into their diagnosis. And unfortunately, I do have patients that are similar to you that have more aggressive and a faster rate of getting to that level of disability. One of the things that we need to try to tease out is what are those predictors? How do we determine what trajectory a person is going to go on, and how can we intervene at the earliest time possible with the best medication to hopefully help to impact either delaying that level of disability or preventing that level of disability.
Looks like he muted himself back, but there's a question, and I hope I'm pronouncing this person's name correctly. I'm sorry if I am not, but it looks like Douala. And they say that they had COVID at the beginning of the year, which led to an MS flare. And their x-ray shows that they are free of pneumonia, but they've been using a walker to get around, which was not a problem, or they didn't have to do that before they had COVID. And we want to know if you have any suggestions that will help them regain the strength in their legs.
So in general, in someone who has an MS relapse for what various reasons it may be, post-COVID or just ineffectiveness of their disease modifying therapy, and they just have a relapse and they are left with some disability, the best thing that we could do is offer physical therapy, really regaining the strength in the legs, telling the nervous system that it needs to regain that function. So the more active, more focused physical therapy that you can have, the more walking that you do or are able to do, the better off you will be. However, we do know that with each relapse, there may be the accumulation of permanent disability. It does take several months for us to understand whether or not something is permanent. And so usually I suggest to my patients who are in a relapse is that we will do the physical therapy, but it may take 3 months or more to regain your function. The longer the disability remains, the more likely it is to be permanent. But what you can do is therapy, therapy, therapy.
We've got one more question from Latoya. She asks, is there any, or have there been any studies on the mental health of African Americans living with MS?
Yes, so we know that in general, depression and anxiety are at a higher correlation in patients who have multiple sclerosis, and we also see that in African Americans, a higher level of depression and anxiety. So yes, there has been some small studies, again, looking at that correlation, and it does exist. So that stresses the importance of us as healthcare provider, making sure we are addressing those issues and asking the questions about depression and anxiety during the office visit. And if you are experiencing the signs and symptoms of depression, definitely feel open to talk with your MS neurologist or your healthcare provider about what ways you can combat that.
And so sorry, we do have one more question that just appeared in Q&A from Marla. She asks what your opinion on MMJ for MS and spasticity is.
I'm assuming that's medical marijuana.
I guess so.
I'm pretty sure. I've learned some of these acronyms. I'm pretty sure on that.
I'm getting my education here, so.
Definitely. So the role of medical marijuana and the data that we have is very limited. Obviously, here in the United States, given the scheduled nature of marijuana, there are very few to no studies that look at the role of cannabinoids or CBD and THC in the management of spasticity. However, there are some international studies in which in Europe where they have looked at formulations of cannabinoids and the effects of spasticity. And there is some evidence that CBD, cannabinoids, THC as a combination can impact spasticity and pain in patients living with multiple sclerosis.
We got through all the questions, which is great.
Awesome.
I'm sorry we went a little over. I hope that that's all right, but I'm glad that we got to everyone. So if you did miss any part of this conference, it will be replayed on msfocusradio.org, MS Focus SoundCloud page, and on the Multiple Sclerosis Foundation YouTube channel within a few days. However, if you would like to see it sooner, you can by going to the Multiple Sclerosis Foundation's Facebook page. We are live streaming from there at the moment, but after it's over, just give it a few moments to appear on our timeline and you'll be able to watch it from beginning to end. And our next Zoom conference will be with Dr. Mitzi Williams, who will be hosting a panel discussion on the Black experience with MS, or Black African Americans living with MS, I'm so sorry. And that is on Tuesday, February 22nd at 6 p.m. Eastern time. And please do follow MS Focus on Facebook, Twitter, and Instagram for times and access information. But we do want to take time to thank our sponsors and thank all of the attendees for participating. And Dr. Sanders, thank you so much for staying over a little bit to take these questions. We appreciate your presentation so much. It was informative.
Thank you.
Everybody have a great rest of your night, and please, please stay safe. Bye.
Bye-bye.